My name is Shalin Naik, and I'm an immunologist at the Walter and Eliza Hall Institute of Medical Research, often abbreviated to WEHI, and in Parkville, Melbourne. The COVID-19 pandemic is still on the forefronts of people's minds, as we see the knock-on effects to our mental and physical well-being and to the economy. I'm personally still amazed how this crisis continues to unfold and evolve, and how many new and different questions arise in my mind, and I'm sure the rest of you out there. And for that reason, we're incredibly fortunate to have with us today our two esteemed guests, Professor Sharon Lewin, Director of the Doherty Institute for Infection and Immunity, and Professor Brett Sutton, Chief Health Officer of Victoria. These two guests are unquestionably two of the most informed people about COVID-19 in the context of Melbourne and Victoria. So we're fortunate to have them here today to answer your questions. Right, we're going to get launched straight into questions, and I wanted to start with probably the most topical one at the moment, which is the COVID-19 app. So the question from Judy, that's come via email, is the federal government has previously suggested that 40% of the population would need to get the new COVID tracking app in order for it to be effective. And as a follow-on question from that, how does the app work? Should we be downloading the app? Is our privacy secure? And I'd like to ask personally if you both have downloaded the app. Professor Sutton, let's start with you.
Sure, thanks Shalin, and hello everyone. Great to be online and chatting to you today. So yes, I've downloaded the app. It's an app that was introduced to myself and colleagues from the federal government some weeks ago, so we knew it was in train. We've watched with interest as it's been developed, understanding that it's really been based on the Singapore app with some changes to the coding for our context, and it works in a sense doing the work of our contact tracers. Our contact tracers are in their hundreds in 50 Lonsdale Street and elsewhere, doing the hard grunt of contact tracing, picking up the phone, speaking to individuals who are confirmed cases of COVID-19 and finding out who they've been in close contact with. So more than 15 minutes in close contact or more than 2 hours in the same room. So that forms the backbone of contact tracing. This app, I think, helps to automate some of that work and helps to back up some of the same investigations that our disease detectives, our contact tracers would do. So it really works by understanding, reaching out using Bluetooth and understanding what other mobile phones with the app are in close proximity. Around 1.5 meters, it doesn't work exactly, but it certainly picks up a Bluetooth signal when other mobile phones of people who've downloaded the app are in close proximity, and it makes a Bluetooth handshake. And then locks in that interaction and stores it in an encrypted form on that mobile phone. And my understanding is that if there's an individual who then gets confirmed with coronavirus, that they can log that on their phone, that therefore all of those people who've been in close contact, who've had that Bluetooth handshake with that mobile phone, are then logged as close contacts, and those individuals' details are passed on to the state and territory public health units or health departments. And so I think, in some respects, it's going to flag exactly the same investigations that our contact tracers will do. But for some other people, it will flag close contacts that they wouldn't have known about. Someone you might be sitting with on public transport whose name and details you don't know. Someone you might have been in a queue with within 1.5 metres for 15 minutes or more. And so it might automate some of those close contacts that we wouldn't otherwise pick up. And for that reason, I'm downloading it on my phone. I think that 40% figure is obviously on a sliding scale. If it's 70%, it's going to be better. If it's 10%, it's not going to provide nearly as much. But it's all worthwhile in the sense that the more people who download the app, the more of those Bluetooth handshakes that will be captured and will be able to be passed on to health departments.
And I guess my follow-on question to that would be why 15 minutes? Why not 2 minutes or 5 minutes? Is that just because we'd be swamped by data otherwise, or is that based on empirical evidence?
There's there's no hard and fast rule about 15 minutes. It is a figure of some arbitrariness or convenience. We know that, the longer the cumulative face-to-face contact, the greater the risk of transmission. And we think that that's a reasonable cutoff. It's probably pretty conservative. There's by no means are you likely to have transmitted if you've had 15 minutes of face-to-face contact. It depends how infectious the individual is, how symptomatic they were at the time, exactly how close you were, how vulnerable the individual who's in close contact, and all of those things. But we do know that we've defined casual contacts as those with less than 15 minutes of face-to-face contact. In the initial part of this pandemic, we were following up literally hundreds and hundreds of casual contacts, or flagging sites where casual contacts might have been, like open spaces and restaurants where people weren't at the same table. And, in the first 1,000 casual contacts that we looked into, not a single one was confirmed with coronavirus. So for less than 15 minutes of cumulative contact, it does seem, highly unlikely that you might have picked it up. Oh, you're muted, Shalin.
Sorry. Sharon, what about yourself? Have you downloaded the app, and what are your thoughts?
I have downloaded the app. I did it last night. I should say my husband had great difficulty in doing it. So obviously it's not that easy, but I found it quite easily. He won't like me revealing that about him. But I did find it easy. You just have to enter your name and I think your postcode and a few other details. And I am very passionate about using this. This is another extra extra tool in our toolbox of managing our contact tracing. That is the best tool we have currently: testing, rapid identification of cases, quarantining of contacts. And the better we can do that and the smarter we can do that. The Victorian government's done an incredible job. Brett spoke about his army of contact tracers. But if we could make this slicker and faster and easier, acknowledging that there are issues around collecting data. So I really do understand many people's concerns around privacy. I understand that the government has gone to some extra precautions around protecting that data. It's a bit out of my expertise, to be honest, but they understand that's happened. As soon as the pandemic's over, we will delete the app, and apparently that will delete the information as well. There's already so much of our private information collected by others. I'm not trivialising that that's not important, but, this could make a really big difference and make us, I'd be really interested to know, of course, and we will look at this, what extra benefit we get. So we'll be able to actually, systematically look at the number of contacts revealed through this mechanism versus the number of contacts revealed through our standard mechanism. And if there's a big gap there, will be an extraordinary advance for this pandemic as well, for how we manage infectious diseases going forward. So I'm a really big enthusiast of it. And actually, just interestingly, I turned off my Bluetooth earlier because I was having problems with my headphones. And within about 3 seconds, I received a message saying, your Bluetooth signal's gone. Where are you? So anyway, it's working. I know it's working.
Yeah, that's great. Yeah, and for transparency, I've also downloaded the app last night because on balance, I personally felt that privacy concerns versus public health benefit was far in favour of public health. So that was my decision as well. And Professor Sutton, a follow-on question: does this rely on people confirming that they've had COVID-19 if they get tested and report positive, or does the reporting of the positive come from the government? How does that work?
No, it's all voluntary. It's all opt-in. So that individual who gets confirmed with COVID-19 has to flag it on their phone, has to give that additional permission to say that information is then shared in the sense of initiating the close contacts who've had that Bluetooth handshake within the infectious period. So it only relates to the time that someone's become symptomatic and for the period of time that they're infectious. And for all of those periods where data is stored and you're not a confirmed case, it's held for 3 weeks and then it's simply dumped. No one gets to access that encrypted information on their own phone. And when it's not relevant because you haven't been a confirmed case, then that data is lost.
Wonderful, thanks. If you've just tuned in, you're watching this month's Melbourne Conversations event from the City of Melbourne Council. This is a live Q&A with some of the people leading Victoria's approach to the COVID-19 pandemic. If you have any questions for our panel, you can drop those in the comments on this Facebook page or send an email to conversation@melbourne.vic.gov.au. So our next question comes from Debbie via Facebook direct message. Will there be a concept of immunity certificates allowing people exemptions from restrictions in the future? This is something that I'm very interested in. Well, can we recruit these people to get out there into our workforce, our hospitals, our cafes, and try to get back to business as normal quicker? Or is there unforeseen problems with that approach?
I might answer that.
Oh, you go, Sharon.
Go ahead.
Sorry, I'll have a go, Brett. So just to be clear, what immunity certificate could mean, or what people mean when they talk about this, is having a blood test which shows that your body has recognised COVID-19. So at the moment, we diagnose people as being positive or negative by looking at for the virus, which is we do through a throat swab. But there are these tests that we use, which are blood tests. We use these sorts of blood tests pretty much for all viral infections because your body makes an immune response and therefore you have a positive blood test. Now, that doesn't mean that you are necessarily immune from getting reinfected with COVID-19. Now, for many viral infections, we do have lifelong immunity. So a great example is measles. You have measles once, you develop your immune response, you get a positive blood test, and you're basically immune for life. If you're exposed to measles again, you won't get it. But that doesn't happen actually with every virus. And unfortunately, at the moment, we don't know if that is the case for COVID-19, meaning if you have a positive blood test, it tells you you've been exposed to the virus in the past. It may not, it doesn't, we don't know with confidence that it tells you you're protected from reinfection. And so therefore, having this sort of certificate, it actually doesn't mean anything clinically. I'm a little nervous that even if it did mean something, it could drive all sorts of behaviours. You know, there'd be an advantage for being blood test positive because you could go back to your job or you could go to the pub and your friends can't go. It would create all these really tricky issues that we'd need to sort out as a community. But in the short term, right now, having a positive test is interesting. It means that you've been exposed to the virus in the past, but we don't yet know if that means you'll be immune from reinfection.
Thanks. And what about you, Professor Sutton?
Yeah, I share some of the same concerns that Sharon has. I think there is obviously this question about exactly how immune we are, how long that immunity might last for, how deep the immunity is, and whether or not we can be reinfected. There's no clear evidence that we can be reinfected, but neither is there really clear evidence that we've got an immunity that prevents us being reinfected for a long time down the track. The whole idea of a certificate, I think, brings in those difficult questions of what does it mean if it provides you a different advantage within society? Do we end up with different classes of individuals engaging in public activity? I would hate to see counterfeit certificates, a black market in certificates being sold. So I think, they're all considerations that would need to be have with an immunity certificate. But the very first thing is, can we really say that you're immune, before we start issuing these? I think in countries where they've got literally thousands and thousands of cases, and there might be a real need to get people back into a workplace at a lower risk, if not a zero risk, then maybe that's more of an issue for them. But I think in Australia, where we're still at 6,000 odd cases, 7,000 cases, it's a tiny proportion of the overall population, and it probably is less meaningful for us in Australia than most of the rest of the world.
Right, so this is an interesting point around knowing you have been exposed to the virus, and that's important, I guess, both from a public health perspective, but also for people's personal curiosity. Is there going to be a time when whether government-sanctioned or non-sanctioned tests are available via mail order? You can pick it up, have it delivered to your letterbox, and get an answer for that. And what are some of the concerns around that if that market opens up in the future?
Well, I think the priorities for testing, and just to be clear, there's two types of tests: a throat swab to look for the virus and whether you're infectious or not, and a blood test to look at the immune response to tell if you've been previously infected and potentially immune, although we don't know the answer to that. And the real priority for us going forward is on tests of whether you're infectious or not, whether you're virus positive or virus negative. That has a really big impact for what we do of clinical response. If you're infectious, you're isolated and we trace your contacts. It has a big impact in the public health response, meaning infectious meaning your throat swab positive. At the moment, being blood swab positive doesn't mean anything. We won't act on it. We just don't know what it means. It's interesting, a very important research question to understand how many people are positive or not. And as Brett says, very likely in Australia, our numbers will be extremely low. Now, could you do these tests at home? Actually, potentially, yes. Both for the infectious throat swab test and for the blood test, there's a lot of work done on what we call point of care tests, meaning doing them in sample, army good, meaning they perform well, they rarely miss a positive, and they really get a positive test wrong. They're the two things we want from a test. And at the moment, there are point of care tests, meaning that you could do them at home for the blood test, not yet for the throat swab virus test. And I'd love to see some advances, and we may well see some advances for the throat swab, and I'll just talk about one possible potential scenario. Because the throat swab for me is the most important test. That's, are you infectious, are you not? Do you need to be isolated? Do you need your contacts traced? Now, at the moment, you go to a testing site across Victoria, and there's numerous different options for Victorians. You have a throat swab done, and it goes off to usually a pathology laboratory for testing. And the whole thing usually takes about 24 hours. Well, we now know that there may be other ways you could collect samples. So people are looking heavily at saliva, and there have been a few very interesting publications showing that saliva also can be positive, and some work being done right here in Melbourne, led by Deb Williamson at the Royal Melbourne Hospital, looking at saliva. So one could imagine that we could have a saliva-based test that you could send in and not have to leave your home. That could be a big advance. And one day we may also have, and that's not too far in the future, point of care tests actually to find the virus or a piece of the virus, I think will get simpler. And I think we're likely to see advances in testing technologies, way before we might see a vaccine on the horizon.
Yeah, that's really interesting. And so, Professor Sutton, with these tests at home, can this be a very powerful tool for Victorian government and federal government to keep track of, rates of exposure and how that might inform public health decision making? And how would that work in practice? Are you guys thinking about that?
We're certainly thinking about it. I think as we're looking to the medium term with this, we want to be able to enable testing to make sure that we're able to understand the situation in Victoria as much as possible, and the convenience of testing, how well you enable it for people is a big part of that picture. So I think, especially a saliva test where it could be mailed out to your home and you could provide it back straight to the laboratory could be one of those game-changing tests. Of course, my caveat with all of this is it's got to be a good test. That in particular applies to blood tests where, you say, it's right 98% of the time. Well, that's great if you've got a lot of disease and you're testing a population where there's a pretty good likelihood of finding a positive case. But if you're testing 1,000 people and your test is 98% accurate, you'll find 20 people and they'll get the wrong answer. And so what does it mean for those 20 people who are told that they are positive when they're not? and vice versa. So I think absolutely we're looking at it. I think it'll be, as Sharon says, really critical for those infectious cases and the need to isolate and contact trace. But for the blood tests and understanding how many people might be immune, how many people might have been exposed in the past, we do need a good test to get an accurate picture, because when you've got very low numbers across the board, you need a test that gives you the right answer almost all of the time.
Right. And on relation to tests, I'll first ask Professor Lewin and then Professor Sutton. There was an interesting study that came out where they tested viral RNA, so the remnants of the virus, not necessarily infectious virus itself, in the sewage of a community, and found that the predicted infection rate was higher than had been reported. Is this a sensitive enough tool? Is it informative? And is that something we could use to track our population broadly by digging around in the excrement of our citizens to get an informed opinion on what's going on in the community without going person by person? Professor Lewin, is this a test that could actually work?
Yeah, this is a really interesting strategy. Not new, by the way. In fact, it has a little acronym, WBE, Wastewater-Based Epidemiology, and we do use it for other virus infections, particularly polio, actually, and anything that will any infection that we know is released into the wastewater. And so, first of all, most people think of SARS-CoV-2 or COVID-19 as a respiratory infection, and we transmit it by respiratory, aerosol, respiratory droplet spread, or coughing, sneezing, etc. That's everyone knows about that. But actually, quite a few people, not everyone, but a large number of people who have COVID-19 also have the virus detected in feces, which tells us that the virus probably infects the gastrointestinal tract as well. We saw this definitely with other coronaviruses like SARS. And so therefore you can find virus in feces. And therefore if you can find virus in feces, you can find virus in wastewater. And this has been used to look at polio outbreaks and to look at, particularly because some polio vaccines can also be excreted in the wastewater. So people actually have done this, and they've looked for SARS-CoV-2, even right here in Australia, in Queensland actually, and you can find it in that they have been able to find it in the sewerage system. And so a number of groups, I understand, in the ACT and potentially in Victoria are going to see whether this is a tool for looking at what we would look at sort of overall community prevalence. There's some nuances in how that data will be interpreted. It sounds like science fiction, but actually it's not. There's a track record of us looking at viruses in that way, and could well be used for COVID-19.
Professor Sutton, could we use it to detect a tsunami of infection rates in Australia? Oh, too funny. Thanks. We are, in fact, already planning on that. So Victoria is part of Water Research Australia network that are looking into this across many jurisdictions. And we're going to do sampling of our wastewater treatment plants. You take a small amount from the inflow. That's a collection of how big the sewage catchment is. And as Sharon says, detect the virus if it's present. I think it'll potentially do two important things. One, we might be able to validate it in terms of the quantity that's found, if there's some correlation maybe with the burden of illness that's out there, and maybe we'll see the quantity that we can detect diminish over time. It's very hard to know at this stage if that can be correlated, but I think it's worth exploring. The other thing is, if we detect it in catchment, sewage catchment areas, when we know we've got infectious cases, in hospital, in the community, in home isolation or in hotel quarantine, then we see it disappear from sewage. Do we see it disappear when we see all of our infectious cases recover? So is there some kind of correlation that we can make between the number of active cases that we have in the community and the detection of virus in sewage? And so it might be particularly important if we're going down an elimination strategy where we're trying to see no transmission at all. And so you've got a kind of extra validation for there being no transmission in the community. A, you've got no active cases, but B, you've got a backup surveillance system where you see no virus in the sewage system, and you obviously have to do surveillance across all of the sewage catchments in Victoria. But it's not inconceivable, and I think we should have it in mind. It's another check of your surveillance strength and robustness. Are we missing some cases through clinical case detection that we're then picking up in sewage? Does it tell you that you need to go back out, do more testing, really prompt people to come forward because you're seeing it in the environment, as it were, but you're not seeing it in your clinical cases?
Great. And just a clarification question, since we're talking about the virus in faeces. We might be now suddenly worried about virus in the feces. We should all be washing our hands after number twos anyway, but is this actually a route of transmission, or is this detection of virus in the poo? Is the primary source through the sneezes and coughs, or can it also be transmitted fecal-oral? Professor Lewin?
No, it theoretically could be transmitted fecal-oral, but it's not reported. So the respiratory route is how it's spread, but we do find it in faeces. And it was similar descriptions, as I said earlier, about with SARS, or the original SARS. It actually did play a role in transmission in SARS, but not reported for COVID-19.
Right, thanks. Professor Sutton?
Yeah, as above. Thank you, Sharon.
As above. No worries, thanks. All right, so let's switch now gears a little bit to discussion around what we can do to prevent virus spread and what we can prevent to do, what we can do to prevent being infected ourselves. So, the public message has been hand washing, social distancing, but let's talk about masks, which I know has been quite controversial, has been taken up a lot in other countries. We also hear that masks really are best to protect you from infecting someone else rather than being infected yourselves. But if that is efficacious, why aren't we spreading it around the community? And that question comes from Janat on Facebook Direct Messenger. Professor Sutton, let's start with you this time.
Sure. Look, it's an important question. We do know that masks clearly play a protective role. That's why our healthcare workers wear masks at work, and why you should wear a mask when you're dealing with someone who's infected or probably or suspected of being infected and having COVID-19. So they do play a role, but it's most important for that individual who's infected. You prevent a lot of the droplets from being able to transmit to travel so far. So it is most critical for the person who's unwell, whether or not they're confirmed diagnosed with COVID-19. If you're symptomatic with cough and cold symptoms, then it's most appropriate for you. For everyone else who's well and out in the community, I guess there's been a great debate. A lot of the countries that have been successful have been countries where it's been pretty much a community cultural standard. Singapore, South Korea, East Asia in general have high rates of mask wearing. Now, whether that is a significant feature of them being able to control the pandemic, I'm not so sure. I think there are lots of other elements about how well they've complied with social distancing, the strength of their public health systems, the kind of other interventions that they've taken. I think for Australia, it's fair to say that, we've struggled to have a sufficient number of masks for our healthcare workers for some time. There's been a huge increase in the amount that's been acquired and purchased now, and we have tens of millions of masks available for our healthcare workers. But it was a pretty clear message that if we're going to prioritise masks for anyone, it should be for our healthcare workers. And I didn't want to see, and I think the federal government didn't want to see, people going to private stocks or otherwise going to stocks that might be available for purchase for our healthcare workers by governments or by private institutions. And so I think it was less value for the well individual out in the community, especially if you're practicing social distancing and especially if you're not symptomatic yourself. And if we can get the message around hand washing, keeping your distance, and if you're unwell, not to be in the workplace, not to be out in the community, then I think that does as has been shown by what's happened with transmission in Australia, that does the grunt work in terms of suppressing transmission.
Right, so is the feeling that mask wearing could provide kind of marginal to those other kind of key public health measures? Is that the idea?
Exactly, and I think physical distancing is one of those key ones, and we shouldn't underestimate what hand washing does, and the fact that, you know, our hands go to our faces, well, they used to, about every 3 minutes. So, you know, 20 times an hour, it's a very easy way to pick it up from a surface or to transmit it from one hand to another hand to a mobile phone, whatever. So shouldn't be underestimated as a public health intervention.
All right, and Professor Lewin, what are your thoughts on this? And maybe tell us a little bit about how the virus comes out of your mouth and you touch it. Can you get infected through the eye, through the nose, through the mouth, all of the above? Where's it actually getting it in?
So just going back to whether we should or shouldn't use masks, as Brett was explaining, why they might be useful. I think it also depends a lot about how much virus you've got in your community, because in the end, mask wearing, my interpretation is that it will only work if everyone's wearing it, because basically the point of it is that there are people in the community who may be infected and don't know it, and the mask will stop them from spreading it. So it won't necessarily protect you if you're uninfected. It will stop people, as you said earlier, Shalin, which means that everyone has to wear them. And then if you've got so few people in the community, you're using up all these masks when we really should be preserving them for hospital care. So I think the decision to use or not use masks depends a little bit about how much you've got in your community. For example, in New York City, masks are compulsory and people are wearing them, but, you know, they've got very, very high rates of infection in New York City, very different to us. Now, how does the virus spread? Well, we are very confident that this is through droplet spread, which means that every time you cough or sneeze, or maybe even just sing, apparently, or talk, maybe just, you know, talking, you're releasing droplets from your upper respiratory tract, and if you're infected, there'll be virus in those droplets, and then those droplets will spread onto surfaces around you or contaminate someone directly. You touch an infected surface, and then you touch your nose, your mouth, or some mucous membrane. That is how you become infected, which is why the rules around hand washing and not touching your face and physical distancing. What's been a little, and we're very used to this sort of measures, because that's how influenza is spread, predominantly through droplet spread. Then the other way that respiratory infections can be spread is through something called aerosolized spread. Basically means the virus is in much, much, much smaller droplets. You know, there's a size which we distinguish between droplets and aerosolized. And there are infections that they're usually much more contagious if you spread through aerosols. And it's been a little bit controversial about how much of coronaviruses generally, and particularly COVID-19, could spread through aerosols. And there's some evidence that the virus does stay in, you can detect in the air for a short period of time around someone that's infected. But in the big scheme of things, overall, the majority of spread is through droplets. We would use a very different containment strategy if it was aerosolized spread. And actually, sometimes we do protect ourselves for aerosolized spread. So, for example, in hospitals, when you're talking to a patient, you would be wearing PPE that protects you from droplets, which is usually a mask and goggles and a gown and gloves. If you were doing a procedure on a patient, for example, looking into their lungs, which very rarely needs to be done in people that are very unwell, or putting a tube down someone's throat if they need assistance with their ventilation, what you would do in intensive care. Those settings we know can stir up the virus much more, and therefore we use higher level PPE. And I think, so we reserve that higher level PPE in situations which are a higher risk of aerosolizing the virus. But day to day, although we know the day-to-day it's droplet spread, the question is that, you know, maybe you don't need to be coughing and spluttering to spread, which was new. We didn't know that before.
All right, thanks for that. Well, I'm certainly going to be singing much more softly or in my head when I'm out and about after that comment. And I guess related to that, let's talk about flu and social distancing, and also how it relates to coronavirus. So the question comes from Tanya on Facebook. Why don't we recommend social distancing in flu season when more people die? And my understanding is we've actually seen flu, which we were worried about in terms of early wave of infections coming, have plummeted again because of, as a byproduct of our social distancing from flu. So do you think this might become the norm during seasonal flu once coronavirus is gone? Professor Sutton.
Yeah, it's a good point, and I think clearly social distancing has had an effect on flu. We're seeing some of the lowest confirmed flu numbers for this point in the year, in the season, for many years. And it must be down to social distancing and the other hygiene measures that we've taken. So it does have an effect. I think on the point of how many people die from flu and how many people have died from coronavirus, clearly in Victoria, we've stopped significant numbers of deaths from coronavirus, but the estimates would have been that would have killed several-fold more people than a normal flu season would. There are about 3,000 people who are estimated to die from an average flu season in Australia, and it would vary year on year. So it's never insignificant numbers with flu, but coronavirus would have, if we hadn't gotten on top of it in the way that we have, killed tens of thousands of people in Australia. So several-fold greater than a normal flu season. I think in terms of future seasons, yeah, we've created new habits, and I think physical distancing will be one that is a good habit to maintain. But obviously, I think we've needed to take extraordinary measures for coronavirus because of exactly how severe and infectious it is. And it'll need to be proportionate with flu. We've also got a vaccine that'll be available every season for flu, which plays a big role, and all of the other messages that we have around covering your cough and hand washing will also apply to flu. But I think physical distancing is another one of those things where maybe we'll queue up differently. Maybe we'll move around the streets a little bit differently during a flu season as an additional measure, and I'm sure it would have an effect.
And just related to flu vaccine while we're on that subject, although influenza and SARS-CoV-2 are very different viruses, how important is it for people to get the flu vaccine this season in light of what's happening? Professor Lewin, let's start with you and then let's go to Professor Sutton. Sorry.
Yeah, getting the flu vaccine is really important, and it's available now, and we recommend people to be getting their vaccine. It's important because people that get severe, having both infections is a very bad combination, and we want to protect especially people that have comorbidities, and meaning other illnesses such as diabetes or high blood pressure or obesity, and as well as the elderly, because those are the same groups that are also at risk of severe COVID-19.
Professor Sutton?
Yeah, absolutely important. Victorians have responded. I think everyone in Australia has responded, maybe under the shadow of coronavirus, but we've had 750,000 more doses of vaccine distributed in Victoria. That's a really significant step up. Whether that's just people getting it earlier or a really significant proportion of people who've never had it before, I think it's probably a combination of both. But I think for those people who are vulnerable, who are at risk, it's absolutely a good thing. It'll be a good thing in protecting them from influenza, let alone the possibility of being infected with both. So it's a terrific response that we've seen, and I'd encourage people to carry on with it.
Wonderful. And while we're on the subject of vaccines, we have a question from Adam on Facebook. Can we get an update around vaccine research and whether Sharon is concerned around human trials commencing so soon? Or I might ask the flip side, how excited are you about trials commencing so soon?
Well, it's a really excellent question, because the pathway to developing a vaccine in the setting of a pandemic is quite different to the pathline for developing a vaccine in peacetime. And that's because there's this urgency of the need for an effective vaccine. And so what we're seeing in COVID-19, so usually the pathway in developing a vaccine is that you test it in an animal model and you show that the vaccine induces an immune response in the animal model, and then you test it in an animal model and challenge the animal with the infection to show that the animal's protected from your vaccine, and then you've got good evidence that the vaccine is immunogenic, induces an immune response, and also protects. And then you would move into clinical trials, and the pathways with clinical trials is what we call a phase 1 study, which is proving that the vaccine is safe. Now, safety is a huge issue for vaccination because remember, you're going to be giving a vaccine to all these otherwise healthy people, and not just a few 100,000, millions of people will be receiving this vaccine. So you want to really know it's safe. So phase 1 studies are for safety, and then you move into phase 2 studies, which is for immunogenicity, showing that it will induce an immune response and or some efficacy. And then phase 3 studies are the big trials to show that it protects and reduces infection. So, that's sort of probably a little too much detail, but it just shows you how, I want to give you a sense of the various steps that are needed. Now, when you're normally developing vaccines for most other things, this takes years and years and years because you are slowly advancing through all these steps. Now, what's different here with this particular pandemic is there is great urgency. A vaccine would have an enormous impact on what we are currently doing. And all of us are very hopeful. We may not see one, but we're very hopeful that we will get a vaccine, and ideally the shortest time that we might see it, 12 to 18 months. So to compress that pipeline, what some companies and what some investigators are doing, and it's supported by the big funders of vaccine research, is that if your product looks promising and it's inducing an immune response in animals, and you may not have shown protection yet, it's worth proceeding to understand safety, at least with a phase 1 study, because that will, by sort of pushing those two pathways along concurrently, you will save time. And I think that does make sense. It's a more expensive way of doing things, of course, because humans trials cost a lot. It costs a lot to make the vaccine at a grade that's suitable to put into a person as opposed to put into an animal. So you may waste a bit of money along the way, but, we've got high stakes here. And so there are 2 human vaccine studies currently underway. One of them is in the US, which is looking at a very novel form of a vaccine, using the genetic material of the virus rather than a protein of the virus. Traditionally, when we vaccinate people, we use bits of the virus, which is using the protein, so the parts of the virus that are produced to generate a vaccine. And a new approach is to use the genetic code of the virus, or what's called an RNA virus. And those studies are underway in humans to look at phase 1 at the same time that they're being tested in animals to show protection from infection. And a similar study is happening currently in the UK with a different vaccine approach, which is testing in phase 1. So it's pretty extraordinary. The RNA vaccine story is really incredible because they were able to generate that vaccine. And I should say there's been lots of work on RNA vaccines in other infections, particularly in HIV, which is the area that I normally work in and know quite a lot about. So these HIV vaccines, so the platform has been there, but there aren't any licensed vaccines. Because they're just using the genetic code of the virus, they were able to make the vaccine in some extraordinary record time. I think it was sort of in the order of 2 months after the release of the genetic code of the virus back on January 7th. So it's pretty new technology and potentially very exciting if it works.
That's wonderful. And I know the world's hoping for a vaccine, and we need that to achieve the herd immunity, which is where there's enough people who are vaccinated to prevent community transmission. And Professor Sutton, is this something we have to wait for before? We have a question here from Janet on Facebook. do we have to wait for a vaccine before we can see our grandchildren? I know my parents are, feeling a lot of heartache around that. What's the answer around that? Is it we have to wait 12 to 18 months? Surely not.
No, not for those kind of liftings of restrictions. There are many things that we can lift in layers, in little bundles. There must be a dozen different layers of restrictions we have at the moment in terms of how many people we can meet when we leave our house, the workplaces that are closed, the remote learning for schools. But we can lift them in layers, see what happens with transmission, see what happens with numbers across the country, and then be satisfied that numbers aren't ticking up, that it's not going to get out of control again, and then move to a lifting of another bundle of interventions or layers of restrictions. And I think, we're all feeling it. I haven't seen my mother face to face for weeks. I've got my kids at home doing school as my wife is at home working, as I'm at home working. It's a pretty chaotic household, and no one, really likes it. And I'm lucky in many respects. I get to come to work for a start. But, there are elements of challenges to our well-being that we shouldn't have in place long term, because they really are significant. And so being able to see our loved ones has to be lifted in time. And I think we will look at the public health risk and the well-being benefit in concert as we make decisions around it. And seeing our grandparents, seeing our grandkids has got to be relatively early in the lifting of those restrictions. The issue about a vaccine is that we can't see a full lifting of some of these physical distancing interventions until there's a vaccine in place. Because if we were to go back to normal, with all of the mixing, all of the workplaces, all of the crowding on public transport, we would simply see one person infecting 2.5, and that would exponentially increase cases, and we would get back to hundreds of thousands of cases in relatively short time. And so there has to be some level of restriction that will be longer term, and a vaccine will be the game changer in terms of being able to lift those restrictions, because it will provide that broad-based population level of immunity that means that we can lift those restrictions without seeing an epidemic take off.
Great. And specific to that question, when can grandparents officially see their grandkids again?
Look, I think some will already be seeing their grandkids because they're providing a care role, and that's one of the reasons to be able to leave home. That's one of the reasons that someone can come into your home to look after your kids. For the broader restrictions, I think, we have to wait for National Cabinet to make a decision around some of those interventions. I would like to see, some consistency of messaging across the country for some of those important restrictions. But we need to make a call also based on how things are going in Victoria. I hope it's sooner rather than later, but I can't preempt stuff when we're not there yet. I don't think it's far away.
I understand. Just a question from Laura on Facebook that I might answer quickly on the topic of vaccines. There are many countries currently working on a COVID vaccine. Is there a communal vaccine portal platform where doctors and scientists can discuss, compare their findings? My take on this is I'm a big fan of these two preprint servers called bioRxiv and medRxiv, which came out of Cold Spring Harbor a few years ago, which allow early dissemination of results to the scientific community without waiting sometimes a year or two for journals. And that has seen an unprecedented response in response to coronavirus epidemic. Now, by and large, this research is incredibly useful to transmit information to other scientists and doctors to see what they're working on. There have been a few cases of research that's been a bit dubious, has led to some questionable outcomes, but I think on balance it's very powerful. So as long as people understand that a preprint is not something that's been peer reviewed by the community and is not kind of gospel fact, no science generally ever is. It's the accumulation of ideas that stand the test. I think it's been a really powerful platform. But Sharon, I'm curious to understand, maybe amongst some of the biotech companies, I've heard there's some unprecedented collaborations between biotech companies to try and find a vaccine here. Just briefly, How do scientists talk to each other, and how does that happen?
Yeah, I was going to add to what Shalin said. There's, of course, what we read in the pre-print publication space, which is coming out early. But there are actually several other networks where scientists are talking about different aspects of the response, particularly on vaccine development. The WHO convenes a global community of people working on vaccines, industry and academia. And we from the Doherty Institute are represented on that call, for example. And I understand that there's incredible openness about what people are doing, because there's lots of different pieces of the puzzle here. It's not just the vaccine. It's the tests that you evaluate the vaccine, whether it's immunogenic or not. They're the animal models that you're using to do your challenge studies. There are the designs of your phase 1 study. There's actually quite a lot of technical components in vaccine development beyond just the idea of the vaccine construct you're using. So that's one forum. And the other is a really interesting organisation that we're very lucky was established back in 2017. And that's an organisation called the Coalition of Epidemic Preparedness and Innovation, or CEPI, C-E-P-I. And it's actually a global funding agency based out of Norway that was established after the Ebola outbreak in 2014. Some of you may remember that biggest outbreak of Ebola ever, 11,000 people died, all in West Africa. And there was alarm across the world about how unprepared we were for that one. And that was, we didn't have a vaccine, we didn't have antiviral drugs. And although some companies had been working on them but never progressed them to market because they just didn't have the support for it. So what this global agency, CEPI, did was they established a very large pool of funds, largely through the Gates Foundation, the Wellcome Trust and the Norwegian government. Actually, the Australian government contributes to CEPI as well. And many other countries contribute at lower levels than the Norwegian government. And CEPI funded initially about 8 to 10 groups who had good vaccine platforms that could rapidly adapt to a new virus. And several of those CEPI-funded groups are now working on coronavirus vaccines specifically for COVID-19. One of those groups happens to be in Australia, which is fantastic, coming out of University of Queensland, and that group collaborates with many people around the country as well. So those groups are also in active, so the front runners of developing COVID-19 are all sharing data because they're largely funded through this one agency. So one has to think, going forward, we should be, what are we going to do that's at a far greater level than what CEPI's been able to achieve as a global community? Should we have a similar entity for developing antiviral drugs or testing, which is the things that we're all scrambling to do now, or despite a lot of investment in preparedness. But we could probably get far better investment and collaboration globally using a similar structure to what CEPI established back in 2017.
That's great. And so maybe we turn our attention to actions looks like and what the parameters for that might look like. So the question from Daniela on Facebook is, what is an acceptable number of known local transmission cases before social isolation bans can be eased? How do we avoid a second wave of outbreaks such as is happening in Singapore? So I guess right now we're looking for elimination and then we can open things up back gradually, but this is going to be a long-term proposition. What's the thinking here, Professor Sutton?
It's our big existential question. It's a really, really tricky one. The essence of it is we have gotten down to very low numbers because we have pushed transmission right down. Unmitigated, so without any intervention, one infected person, we think, would infect about 2.5 other people. So 10 people would infect 25 others in a generation of infections being passed on. That's what it looked like out of China. In Europe, when it began, it grew at that kind of rate, 2.5 people infected by one. To turn it around, to have a flattening of the curve, you need to have that reproduction number move from 2.5 down below 1. We've done that, and we did it earlier, which has pushed our numbers down to single figures in Victoria, to about 20 every day or fewer across Australia. Other countries have also flattened the curve. They probably also pushed their reproduction number down below 1, but they were having 4,000, 5,000, 6,000 cases per day, and so they're plateauing, but still with thousands and thousands of infections and hundreds of deaths per day as a consequence. And so the absolute number is not so much the issue. I think now that we're at very low numbers, we can be satisfied that we've got things under control and we can manage it from a public health response point of view. It'll be about the assurance that we've got that reproduction number remaining below 1, because as long as it remains below 1, we'll continue to suppress transmission. And if it goes above 1, it doesn't matter if you've got 1 case or 10 cases, it'll start to take off again. And so the easing of restrictions is really about taking those few levels of physical distancing restrictions off, and then watching that reproduction number. And we've got some forecasting, some nowcasting as it's called, where we can almost watch that reproduction number in real time based on the numbers of cases that we're seeing, and with some other data to triangulate to help validate that, including the Google Mobility Index and Facebook that provides some kind of validation for how much moving around we're doing, where we're spending most of our time, how much we're spending out in the community. And I think if we can just watch that reproduction number over time, have a reasonable assurance that it's staying below 1, then we'll continue to lift restrictions over that time. In terms of what's been flagged nationally, May 11 seems to be the day on everyone's lips. That's when National Cabinet has said that restrictions should really remain in place, and then after that date should be an exploration of lifting, and I think Victoria will follow suit.
Great. And related to that, there's the trolley problem, which is an ethical and moral dilemma thought experiment where a train is headed towards 5 people tied to a track, and you have the power to turn a lever to divert it to 1 person who is tied on the track. And apart from this being a really grim question to ask at a dinner party, how do governments grapple with these decisions that things like chronic illnesses, domestic violence, suicide, and other unforeseen deaths will not overtake deaths related to COVID-19? Especially as some would argue that COVID-19 targets a different demographic to those other deaths. Not me personally, but this is the kind of discussion that's going on in people's minds. How do we balance one death versus another?
It is an awful dilemma. I've flagged to my colleagues previously that we can take an awful pathway or a terrible pathway. None of them are great. But foremost in my mind is that the consequences of letting transmission run with coronavirus is not just the very elderly dying. What's been clear from the pandemic spread internationally is that the numbers of deaths are so great that you cannot but avoid previously well people, relatively young people, people who would have 5, 10, 20, 30 years of their life remaining, who are going to die in very significant numbers. Even if it were only those who are in nursing homes with maybe an average of 6 months of life to live, it's still not just a question for me. That's a question for broader society to make value. So I guess the trolley problem in part is solved by us all contributing to the answer and not for decisions to be made alone. But I have absolutely reflected on the fact that there are very significant harms in the kind of shutdown of our movements and of the constraints in our lives. I know that there are challenges with being at home continuously from a mental health point of view, from a physical health point of view. Family violence and interpersonal violence is absolutely challenged in this environment, and they have to be weighed up in the great picture of where we take action. But I know the Victorian Government has invested strongly in response to be able to support people with mental health issues and in the family violence space, and that's appropriate. But we need to watch it very carefully. We need to be assured that there aren't going to be greater harms by virtue of the constraints that we have in place versus that of infection. But I would say please don't just look at the number of cases that we have now, because the counterpoint is how many cases we could have if we hadn't done what we've done. And it literally would have been thousands of deaths. And it's hard to make that point when the modelling is challenged, because all models are wrong from the moment that you see them, because you do things that change the way that models go as soon as you see how they would have panned out if you hadn't taken action. But you only have to look to Northern Italy, to parts of Europe, to North America to understand exactly how it could have played out if we hadn't taken really significant action in Victoria and across Australia. And the other point I'd make is those countries across the world are in harder lockdown than we are. And they're in harder lockdown because they got to a point where it had gotten away from them. Spanish children have only left their homes for the first time in 6 weeks. People couldn't go for a walk beyond 200 metres from their house. Now, we don't have those constraints because we acted early. So rather than about how severe the lockdown is, I think it's about the timeliness that we've taken, and we'll actually be able to lift to a freer point by virtue of how few cases we have now in Victoria. But you're right, it's an impossible dilemma, but we just need to be really cognizant about the harms on both sides.
Yeah, it's a real tough one, I can imagine, and I'm sure the healthcare industry is very thankful for Australia's approach, because they're kind of at the front line of what happens when the pandemic gets out of control. Professor Lewin, is there anything you want to add to that discussion?
Yeah, I thought I'd just add two things. Not only when you get, if the runs on hospitals is greatly increased by very large numbers of infections, you have huge impacts on healthcare in that acute setting, because you actually physically have a totally overwhelmed healthcare system. So I was having a chat to a ex-student of mine, actually, who works in northern Italy, who was telling me at the peak, he's in a town called Pavia in Lombardy, told me that over 70% of their hospital was COVID-19 patients at its peak. So all of those other patients with chronic disease can't get access to the hospital. So there's incredible impact at the time when the healthcare system is overwhelmed. The other thing is that COVID-19 has actually shifted a big the way we practice medicine, and what it has done, and we're all learning how to do it better, both clinicians and patients. And some of those shifts have been really positive. So use of telehealth, that people will have varying views on. Some people like it, some people don't, both doctors and patients. But it will actually change the pressures on our healthcare system. And I think while we're in semi-lockdown, or we just have to work really, really hard to use these other avenues of communicating with people with chronic disease. And, it's interesting, I saw in the paper today, Peter McCallum reporting how, presentations to hospital for cancer has decreased by 30% or something. And a lot of that is it's not because the hospitals are unsafe. It's Peter McCallum want to see their patients more but, patients are feeling unsafe. So we need to be reassuring of patients that hospitals are safe places. We, of course, are reading about some outbreaks in hospitals, we are making them safe. We have alternative ways of delivering care through telehealth, and we've got to, and they may stay with us for a while. There may be some real advantages of people not having to drive, an hour into the city, finding a car park, sitting in a waiting room for an hour to see the doctor. That's what happens, I'm sure, in my clinics, and when they really could get a script over the phone very quickly. So I think we will see some good, we worry, and we should be worried about mental health and chronic disease, but I think the health system's never had such a big shake-up ever, and I think there will be some good things that come out of it that give us maybe even a better model of care in already a very highly functioning healthcare system that we have in Australia, but we may even see some improvements.
That's really interesting. I know from anecdotal evidence that people who are just kind of saying, this problem's not that important in the context right now, I'll let it slip, and then coming to emergency rooms rather than getting it treated earlier. So I think the message really needs to be clear that if people are feeling unwell, please call into your doctor through telehealth or your medical practitioner. Sorry, Professor Sutton, did you want to
No, I was just going to reinforce that. People absolutely need to look after themselves in the way that they would routinely. If they can have a telehealth consultation that they're happy with, by all means. But if they're unwell and they need to see someone, they need to go to the emergency department or the hospital, they should absolutely do so.
Great. I wanted to move on now to travel restrictions, I guess both locally and internationally. So there's this talk of an Australia-New Zealand bubble. There's talk of easing travel restrictions interstate. The question comes from, where does the question come from? Alan, via email. Are all travellers returning to Victoria quarantined in cities or hospitals? And if not, who decides which cases are exempt? And I guess my broader question is, can we just kind of shut our borders and get to business as usual with aggressive track and trace strategies in the future?
Yeah, so at the moment, and it was a decision of National Cabinet, all states and territories are doing this, was a move to mandatory quarantine for everyone who's arriving internationally, and that includes in Victoria. So by default, people go into mandatory quarantine in hotels. There are some exemptions if someone is unwell and can't be looked after in that hotel setting, they're exempt. People who are immune because they'd already been infected and they can provide documentation of that they've recovered, and you know other people who might have significant psychological or psychiatric challenges in being in a hotel room. The exemptions team within Department of Health manage that. It's not my decision to make. I should probably rightly be at arm's length, but those cases can be made to our authorised officers under the Public Health and Wellbeing Act, and they provide the assessments through a general practitioner or nurse or mental health nurse to be able to provide the evidence that someone can be looked after elsewhere or might need to go to hospital.
Right. And Professor Lewin, what's your view on, once we've stamped things out, to kind of opening up our little bubble in Australia and New Zealand? Is that something that's on the cards? Well, not necessarily from a policy perspective, but from your view as a virologist, can we ever fully be confident that we can close off our borders to the virus internationally?
Well, I think this gets back to a principle of where we're headed in the next few months, and the two schools of thought of what we could achieve in Australia, which I should add is pretty extraordinary. Very few other countries are in this position of either elimination or sort of long-term suppression of the virus. Elimination actually means, could we be coronavirus-free? Could we have countries that are actually truly coronavirus-free? There's quite a lot of effort will need to be going into a strategy towards elimination with potentially, harsher and longer lockdowns. But we have a mechanism of understanding if a virus is eliminated, which is essentially zero local transmissions, and then we wait for a period of time, which is traditionally 2 incubation periods of the virus. So an incubation period means the time between you becoming infected and demonstrating symptoms. So for COVID-19, that would be sort of 2 to 4 weeks. Now, if we could really do this, and there are different schools of thought whether you could or you couldn't, and certainly New Zealand have been going for this elimination strategy, it would mean that any travel would be, could disrupt the elimination. The benefits of having COVID-19 eliminated in Australia. But there are ways around it, which I think would be that you would have the same sort of approach that we're having right now to international travel, which is of a period of enforced quarantine, and you'd have to maintain that. And that would still, of course, have a big impact on our economy. It would have a big impact, still completely damaging for our tourist industry. So there'd be major consequences of that, but it is one option that people are thinking about. and therefore you might have free travel between COVID-19 free countries, let's just say with New Zealand. Probably a more realistic strategy going forward is of long-term suppression, which is actually in both strategies you need very good testing, tracing capabilities, but in the suppression strategy you'd be exercising them more regularly because there'd be a low level of infections in the community. And even then, I think, and Brett will probably want to comment on that, but I think you would still have to have the similar approach to how we manage returned travellers. And, you know, what's really complex about this whole situation is that the world around us are all in different phases of the epidemic and will have different levels of infection. And that will be changing quite significantly over the next 12 months. We're all focused on the US, UK, Europe, and the very large outbreaks they've got there. We're not hearing a lot about what's happening in Indonesia and India and Papua New Guinea and countries that are right on our doorstep, and almost certainly we'll be hearing a lot more, I think, about what's going on there. So every country is going to be slightly different. So Brett's in the policy space, I'm not, but I think that we will be seeing travel restrictions or limitations on our travel for quite a while yet, particularly for inbound and the same for us going to other countries, if we go for elimination or suppression.
Did you want to have any final words on that, Professor Sutton?
Only to say, yeah, I think it's true. I think our international travel restrictions, by virtue of either of those strategies, will need to be in place. It's a Commonwealth responsibility, our borders internationally, but it's hard to imagine opening up free travel into Australia and being able to maintain suppression. Certainly you couldn't maintain elimination. I think the key difference is that with elimination, the idea is that you then bounce back to a full kind of normal activity within Australia's borders if you can demonstrate elimination. So that has obvious advantages, but that lockdown on international travel, obviously huge impacts for international students, for tourism and for some of the trade implications. But either way, I think it's going to be a tricky business to manage those incoming travellers.
Okay, look, if you've just tuned in, you're watching this month's Melbourne Conversations event from the City of Melbourne Council. This is a live Q&A with some of the people leading Victoria's approach to the COVID-19 pandemic. If you have any questions for our panel, you can drop those in the comments on Facebook or send an email to conversations@melbourne.vic.gov.au. The next question comes from Tamara and Rose in Melbourne. I'm going to combine them into two. Rose is concerned about her grandparents and how bad it is for them. And I guess the related question from Tamara is, well, what does the Victorian criteria for return to school look like in practice?
I might start if that's okay. So, look, it does become a more dangerous virus the older you get, but it's by no means harmless for anyone. I think it's been very gratifying to see that there are virtually no deaths in children under 10, but we've seen deaths in people in their 20s and 30s, certainly in their 40s. And the experience of, the significant transmission in North America and Europe is that people in their 50s and 60s are a big part of those who are being ventilated and hospitalised. So we certainly shouldn't think that it's not an issue for younger adults, even younger adults. But at 70, 80, 90 years of age, the risk of severe illness goes up significantly. And it does depend where you are and how overwhelmed health systems are. But, the death rate, the mortality rate for those age groups increases significantly from, 65 upwards. That's why we need to do everything that we can at a population level to protect those most vulnerable people in society from an age or from a chronic disease point of view. In terms of return to schools, look, I think we're on the right track in terms of how transmission is going in Victoria. There are really three elements to consider with schools. One is that issue of how severe is illness in kids, and I think that's been answered with reasonable confidence that it's a pretty mild disease for the great majority of children, and so my concerns aren't there. There's the risk of transmission to teachers, to other adults in those settings, and we haven't seen significant outbreaks. We haven't seen big clusters, and if we've seen cases, it tends to be from adult to child rather than introduced and then spreading from child to adults. That's reassuring in some respects as well. And then there's the contribution of kids in school together to overall transmission and what it might contribute to community transmission. And again, there are some reassuring models, some reassuring papers about that kids seem to be less often infected. And maybe that relates to their immune system, the kind of virus receptors that they have in their body. But it is relatively scant evidence, and there hasn't been enough testing in kids to be, completely reassuring that maybe there isn't minimally symptomatic or asymptomatic transmission in kids that might contribute to that community transmission. I think nonetheless, Victoria's getting to a point where there's so little community transmission that we shouldn't be too concerned about it taking off in schools necessarily. But I have read a recent paper from Eurosurveillance that talks about the fact that children on an average day in school have about 500 close contacts in terms of person-to-person interactions. They are very active in terms of being in close contact with other children, and that has to be in mind as we think about how we manage getting back to school. But I think we're absolutely on the right track to move back, and I think we'll take the lessons from other states about staggered days or staggered start and finish times, and the other measures for hygiene and exclusion of unwell children to try and mitigate that risk as much as possible so we can get back to on-site schooling at the earliest.
Great. And look, we've got about 10 minutes left to go, and I want to end on a couple of questions, which are basically, what are the questions that people aren't asking you that you think they should be asking you and you would like to have an opportunity to answer? And before we move to that, Sharon, there's a question from Judy, and it is particularly from a Melbourne point of view. How are the research projects at various Melbourne medical research institutes progressing? What are the latest findings? And just give us some insight into how the communication's going there and what's on the cards.
Well, that's a big and complicated question because there's a ton of stuff happening, and I think every Melburnian should be really proud of the medical research sector that we have in Victoria, probably one of the strongest in Australia. About half the government funding for medical research comes to Victoria. That shows you what a powerhouse Victoria is. And across Victoria, we have a range of hospitals, universities and institutes, all of which I know are now active in COVID-19 research. And they are active because, first of all, we have an extraordinary community of people who are experts in infectious diseases and immunology, which are the two arms that are critically important. A lot of experts in epidemiology and public health, and a lot of experts in clinical research. And they're all part of how our all of that's needed in the research response to COVID-19. And at the same time, many of you might not know, but because of the restrictions, all other medical research has shut down. Now, my view is that all medical research is actually essential because, if we're stopping our programs on developing a malaria vaccine, for example, that's going to have a big impact on deaths from malaria around the world. So that's another conversation about what constitutes essential and non-essential work. But I think medical research is pretty essential, so I'm very much looking forward to the opportunity for our medical research workforce to return to work. But at the moment, like Shalin, I think, would be experienced this himself, is that his regular work is on hold. And that means a lot of our, best and brightest minds are all thinking about what they can do for COVID-19 because their other research is not happening, and also most researchers want to make a difference, and this is a big opportunity to make a difference. So this is a bit of a preamble of the scope and scale of what's happening across Victoria, and there's a lot happening. But I'll just give you a few highlights. there is a big interest in treatments for COVID-19. We haven't discussed that at all. But if we had an effective antiviral drug or an effective treatment that stopped people getting sick, stop them going to hospital, stop them from dying, that would have a very big impact on the epidemic, even without a vaccine. And I like drawing a parallel to HIV, where HIV has been around for over 30 years, and we still don't have a vaccine, but we've made enormous strides in managing HIV through antiviral drugs, which have got cheaper, less toxic and widely available. Now, antiviral drugs for respiratory infections have not had a similar track record of success like blood-borne viruses, but there are a few leading compounds, and investigators in Victoria, in collaboration with others around Australia, are looking at treatment trials using different antiviral drugs, trying to use them earlier before people get very sick. Of course, at the moment, we've got very few cases, but we think that we still need the capacity to look at new and novel treatments because they're changing weekly across Australia. Should we get a second wave, we need to be prepared. Other groups, one of them being led from WEHI, which is where Shalin's based, is led by Mark Pellegrini, is going to look at whether an antiviral drug can protect people from becoming infected. And that's a very interesting concept, coming from HIV again and to a lesser extent influenza. But we know that if you take antiviral drugs, very well proven in HIV, and you're not infected, an antiviral drug can protect you from becoming infected. So could we use an antiviral drug to protect healthcare workers, for example, from becoming infected? We know that healthcare workers are one of the highest risk groups amongst family contact members and people in jail for becoming infected. So a study being led by Mark Pellegrini at WEHI, looking at one drug, not a great antiviral drug, but has got activity. You would have heard a lot about it because it's had a lot of publicity, largely through President Trump liking this drug. But there is some value for investigating this drug, but it's not a perfect antiviral. That's hydroxychloroquine. The Murdoch Institute, which has a very large Murdoch Children's Research Institute next to the Royal Children's Hospital, has a very large interest and expertise in infectious diseases and immunology, and they're leading a very interesting alternative strategy for prevention. They're looking at a vaccine for TB as a way to protect you from becoming infected with coronavirus. Sounds kind of crazy, but actually there is the TB vaccine is not a great vaccine for TB, but it's moderately effective. It's widely used around the world, and there's some evidence showing that people that have had the TB vaccine are less susceptible to influenza, and so they're testing whether that is the case for COVID-19. There's a lot of really interesting social research happening at the Burnett Institute, looking at the effects of quarantine on people's mental health. Super important, whether people can or can't comply and the reasons why they can or can't comply. Really interesting social research happening at the University of Melbourne, looking at the interesting, very relevant, looking at the acceptability of an app that traces you and comparing what the acceptability is in Australia versus other countries. I think they looked at Germany and one other country, and interestingly found that the acceptability of an app in Australia was quite high, of around 80%. A lot of work in a very fundamental discovery science, trying to find new and better antivirals. The antiviral drugs that we're using are repurposed drugs. They're not sort of designer antiviral drugs, which we need. That work's happening at WEHI, Bio21, and here at the Doherty. A lot of groups with very good vaccine ideas, which are in the early stages of development. But I should say that down at CSIRO in Geelong, we have an incredible facility that I'm sure the average Melburnian doesn't know about, but we have one of the biggest animal health laboratories in the world capable of doing research with highly infectious pathogens, an incredible facility that was built back in the 80s. And That facility, which has just renamed itself to make itself complicated, but it's run by CSIRO, has established an animal model to evaluate vaccines. They use a ferret model. Ferrets kind of sounds weird to think of using a ferret, but it's a well-established model for influenza. Ferrets can be infected with COVID-19, and they're now testing vaccines from around the world, one from the US, one from Oxford, of whether the ferrets will be protected. So we've got some extraordinary capacity here across Melbourne, and that's just a snapshot of some of the big studies that I can share with you now.
Well, thanks, Sharon. It was quite a difficult question because I personally have also seen so many emails flying around and collaborations starting around trying to, have Melbourne and Victoria's contribution to this disease. And it's been an unprecedented response both here and around the world in what I'm seeing. So I'm pretty excited that we're in good hands with the best minds across, Victoria and internationally. But yeah, it's a wait and see approach, I suppose. Professor Sutton, any kind of final thoughts or comments on questions that you think people should be asking themselves?
I think a really key one for me is how might the world be different a year, 2 years from now? One of the things I think we'll all reflect on is just how challenging pandemics are. In a sense, the 2009 pandemic, it was exceptionally mild as pandemics go. It ended up being a bit like a bad flu season, and maybe we took pandemics for granted in terms of what they could do. This is the worst in 100 years, maybe, and I hope that it raises the profile of the work of public health, the critical functions of modelers, of epidemiologists, of contact tracers, of everyone who works to try and mitigate the risks of these really significant events. Because public health is largely in the business of making stuff not happen, and so it tends to get forgotten when things are going well, and makes the front pages when there's something disastrous happening. But it really is the work of public health, not just in infectious diseases, but in overall population health and wellbeing, tobacco, alcohol harms, obesity, and the like, environmental health and food safety. They're all the work of public health. And so I think a year from now, 2 years from now, we should really think about our pandemic preparedness ongoing, how we use public health more fulsomely in protecting us all of the time, and maybe some reflections on how we can try and mitigate this risk globally, because 75% of new epidemics, new human diseases come from the animal world, and that interface between humans and animals is increasing as there's encroachment on animal territory in the wild, but also in our interactions with animals, with big urban populations. And so we need to have good epidemic preparedness. We need to be able to shut these early epidemics down even faster. This got away from us in the sense that even as Hubei province and Wuhan were shut down, it had gone around the world. And if China had contained it even earlier and it hadn't crossed international borders, we might be looking at a very different picture. And I think China took extraordinary actions and clearly got on top of it, but it had gone to countries that didn't have that capacity and capability. So we really need to think about our epidemic surveillance and response.
Well, I think that's a great note to finish on there, thinking of the future as well. Look, Professor Sutton, Professor Lewin, it's been an absolute privilege to be able to ask you these questions, and I'm sure I speak for everyone who's tuning in from the comfort of their living rooms. We wish you could be here in our living rooms all the time to answer our questions, but thank you for this time. The next Melbourne Conversations event will be on Thursday, the 14th of May at 2 p.m. Dr. Niels Wouters talking about social credit systems, how they work, how they've been rolled out in the world so far, and what a social credit system might look like in Australia. And this is particularly interesting in light of the federal government's plans around an opt-in self-tracking app designed to monitor the COVID-19 situation. Thank you very much again. Thank you very much to our listeners. My understanding is this will be recorded and broadcast at some point on the Facebook page. Thank you for your time. Stay safe, wash your hands, and stay home, especially if you're sick.
Thanks, Shalin.
Thanks.
Thanks, Shalin.